hygiene. Okay. Good morning. This is the lab, right? It's not that exciting. It's not like an actual lab. It's unfortunately, it is very difficult to actually get actual images and stuff like that with all the HIPAA rules and stuff like that. Ideally, what I'd like to do is like actually just get old school x-rays and put them up. We don't have view boxes anymore, right? So it's not what it could be, but it's all right. It's going to be more practice, right? So there's going to be less lecture and me standing up here, yippity yap, right? I'm going to go through stuff. I'll talk a little bit on some of the slides, but then I'm going to put up a picture. And then this is where you guys are going to look at it. You're going to kind of go through it. I'll give you some time, kind of like some of those blue slide picture things. And then there'll be some questions we'll ask to see, kind of give you a barometer of kind of where you're at with looking at things. Don't beat yourself up if something is kind of like we talked about, right? Where there's a lot of ways to describe something like, hey, it's clearly oblique and comminuted, like I see that, but then like the word oblique is missing from the description, right? That's okay. It doesn't mean you're wrong. It just means that that word wasn't given. I've given you a bunch of words of how to describe different things that you see, so that way you can be as thorough as possible, but understand that not every word is always going to be present in a report, or not every word is always going to be needed when you're talking to somebody or when they talk to you, right? But if I don't arm you with the words, then if somebody says it to you, you have no idea what they're talking about, or vice versa. So I have to give you all that information. This slideshow is in Canvas if you don't have it. I don't usually announce it too much because I don't want you guys reviewing it too much beforehand, because that kind of defeats some of the purpose, especially if you go to the next slide, like, oh, there's all the answers, right? And I don't just go through this. So hopefully it's not helpful. But when you do it that way, but hopefully this will be helpful to you guys. It's only 63. We take the whole 2 hours to go through it. We take the whole 2 hours. If we don't, we don't. It's like this is for you to ask questions from a reading standpoint. Then, please, class leader, correct me if I'm wrong. The intent, I believe, is Dr. Friccioni has her portion after this for however long she takes. And the plan is when that's over, that's still the last official thing for the day, correct? When that's over, you're going to have a 15-minute, he's going to text me 15-minute kind of bio break, whatever you want to do to clear your mind. And then I'll come back in for the Q&A review session, which is optional. You do not have to be here for it. And I'll also state this again at the beginning of the review. You can leave at any time. So it's not like once you start, you're stuck here until the end. I will stay until there's no questions and like you guys are good and like that's fine. I don't have anything on the docket afterwards today, so I am at your beck and call for this. I want to make sure I can kind of clarify things for you before the exam. I'm not going to take offense if after the first 30 minutes you're like, I'm good, I got what I needed, I asked my question, it's time for me to go, and you get up and step out. Not going to bother me at all. It's completely optional, so honestly, feel free to do that. It's not like once you start, you're stuck, okay? And we'll just run that until it's, so you guys feel good and you feel comfortable, at least to be able to go back and kind of review it for Friday morning. Questions on that? Okay, let's jump in. This is just to give you that first example of comparing images, right? So this is the perfect one where I was talking about. Femur shaft fracture with apex lateral angulation. We talked about that apex. Which way is the arrow pointing? So if I draw the point of an arrow, right, which way is it pointing? That's how you decide that. That's lateral because the arrow is pointing that way. Now, for those of you that are looking at it, this is why I mentioned at the beginning, yeah, that's probably shortened. It's probably also displaced. It is. But those words aren't on there, right? It doesn't mean this description is wrong. Right? It doesn't mean it's wrong. It just means that you have words to be more thorough if you want to. But in reality, from an ortho standpoint, if you're going to have a lateral apex, that in nature, again, from an ortho standpoint, that's why they like those words. They don't need to know that it's displaced or shortened, because you can't have a lateral apex unless the bones are looking like this. So like that's why they like to use that language. Ortho, they're simple folk, right? I don't mean that in a bad way. They're mechanics of the body. So if you can paint a picture of a word that just means all the things that we've talked about, they like that better. So lateral apex, they're like, great, I know exactly what that femur looks like. Okay. Arrow sign. In case you missed it. Okay. This is just a reminder from the slides of your systematic process. Again, you don't have to do it in this order, but these are all the things in block 1 that you have to look at and look for. Okay? All the things you got to look for. We've seen this x-ray before. You know where the abnormalities are on that one by now because you've seen it 3 or 4 times. This is that reminder. Who's ready to do some cases? Now, your vignettes will not be necessarily this long, right? But this is going to be an example of some information that you could get when your patient's coming in or someone's talking to you. So I will kind of read this to you and get your thinking process going. So 15-year-old female presents to the clinic with left ankle pain after falling off a climbing wall 2 days ago. Pain's 4 out of 10, localized to the ankle, described as sharp. Improvement with Tylenol and rest. On physical exam, a lot of times I may not give you the physical exam in the vignette because that would be too long, right? But in clinic, physical exam is important. A well-developed, well-nourished female with no active distress or acute distress, however you want to read NAD, sitting comfortably with MOC. Anybody know MOC?
Mother of child.
Mother of child, right? But favoring her left lower extremity when walking. So she's limping, right? Visual inspection remarkable. She hurts over the anteromedial left ankle. So now I'm telling you where she hurts. Okay. Full active range of motion and passive range of motion of the knee, foot, toes. However, her ankle is decreased in range of motion due to pain. Strengths 4 out of 5 with ankle pain. There are no special tests for the ankle, and her feet neurovascularly intact. So with that information, would you order images? This is a radiology course. Yes, you would. What would you order? Oh, okay. X-ray of what?
AP, lateral and oblique.
Give me body part.
Left ankle.
Left ankle, okay. X-ray of left ankle. So think about what you would put in that order, right? We don't want to just put pain or patient hurts, right? So going back to this, what do you think some of the pertinent information would be for the radiologist?
15-year-old female, status post-fall 2 days, anterior medial ankle pain.
Okay, and I heard some of that stuff out. Always start with age and demographics. I want to know the age and male or female. That should start all of your orders, right? So 15-year-old female. And you, first sentence for this, I'd just be like, 15-year-old female with left ankle pain for 2 days after falling from climbing wall. That's my first sentence, right? Short, sweet, to the point. Who's the patient? What happened? How long ago? Right? Then your next sentence would be, if you had it and if you saw the patient beforehand, could be, patient has tenderness over anterior medial aspect of left ankle. Please evaluate for any abnormalities. Thank you. Right? So I've given the demographics, mechanism of injury, and how long ago it was, and then just the pertinent physical exam findings. Where did it hurt? Tell me where it hurts. Right? If it's all over, then you just put diffuse ankle pain. Right? Just let them know it hurts everywhere. But if she's point tender in that anteromedial area, that's what we're going to do. Okay. Here's your x-ray. This is the part where I shut up and you guys scroll through your image and do your stepwise process. Need more time? Okay with getting more time. I said, yeah, 60 slides and plenty of time to go through it. Who needs more time? Don't be shy. Okay. So, again, this is for you guys individually, right? So, alright. The green is the normal. Now I'm giving you another picture to kind of compare, give you a little bit to look at it, and at this point, right, I'm trying to help you so you know where you're at, so now you can compare what you thought you saw with what normal is. Build that confidence a little bit. Okay. All right. Did we see the big yellow circle? Yeah. Good. Did you think you were going to be able to see that when we first started this course? No. Probably, right? Confidence building. You guys got this. What would we call this? All right. Let's see what we got. Salter-Harris type 3. So if you found a Salter-Harris 3, good job. Did you notice that? And some of you are saying, well, that's the growth plate. Is that a fracture or is it not? So if you remember we talked about Salter-Harris's, right? It goes through the phyces, goes through the growth plate. That energy's got to go somewhere. So there were two signs of the Salter-Harris here. This clear right here in the epiphysis, and then the energy came out this way. Look at how wide the growth plate is there compared to the other side, right? We can use anatomy to compare things. So this is all the same fracture. It's not a new fracture, right? It's just giving you a mental mind's eye of how that Salter-Harris works. It's through the growth plate right there, and then down in here, okay? What about that one? Is that a fracture? That's just the growth plates.
Right in here. There's a line going down. So maybe this one is
Where at?
going through here and then coming down.
I don't see the down. So, yeah, no, it's just a growth plate, right? And so, I kind of see what you're saying a little bit, but the thing is I don't necessarily have a crack in the cortex. Some people are saying they see a radiolucent line here. I don't, per se, but also, where were they tender? Anteromedial. This would hurt significantly if they had a fracture in there as well. So use that paint, right? When you're like, I'm not sure. In real life, you'll have other pictures too, right? But then also use your physical exam to help you figure out if that might be a fracture or not. Yes?
Is this also where we can keep the picture for the concerned masonry?
No, I wouldn't be concerned about a Mason Nueve fracture. I can't never say that. The French fracture. That's not a large enough gap, especially in peds, right? We were looking at adult x-rays on that one because, again, peds, question mark with their growth plates and some of that size and everything. So if I won't give you a Mason UO on the exam because I said it was FYI. You'll learn that more in ortho. But I'm more worried about that in adults as opposed to peds. So ultimately, we have a Salter-Harris 3 fracture in the distal tibia. That's what that was. What do we do for them? You'll learn it next semester. You'll learn it next semester. David Goblos, and I think for one block, Colonel Sylvester is ready and raring for you guys. Oh, and when they do the Salter-Harris review over there next semester, don't look at them like you've never heard it before. They know you learn it. I think they just did it. They were like, oh, we haven't worked on, no, you may have forgotten it, but you learned it. All right. This is a nice review of the Salter-Harris classification system. Okay. Remember, I will not give you any 5s on the exam because they are darn near impossible to see on imaging. Don't pick Salter-Harris 5. Get all of you. We did talk about some ones like the Skiffy and stuff like that, but again, there's going to be more patient presentation or very obvious slippage. I'm not going to give you anything super finite, but really 2, 3, and 4 is where you're really going to focus on. You don't need a special patient presentation or anything like that. You can pull that out just from the image. Okay, let's do case Bravo. 24-year-old female with 3 days of left groin pain. So like groin, that's muscles, okay. Described as sharp, constant, 5 to 8 out of 10. I always love that one. Rank your pain out of 10. 5 to 8. Fantastic. Depending on their activity. Radiates to the left lower back and left lower extremity. Rice and NSAIDs do not help. No trauma. No trauma. Patient is active duty firefighter who typically completes 2 CrossFit workouts daily. She's uncomfortable on the exam table, but no acute stress. She has an antalgic gait. Does anybody know what that means? Big fancy word for she's limping when she's walking around. She's got an antalgic gait, right? It hurts. Doesn't want to move it like she's supposed to. Visual exam is unremarkable. Palpation is unremarkable. Limited left hip range of motion due to pain. 3 out of 5 strength in the left hip. Positive straight leg raise. I think we're learning that. We're learning that in front skills. Yeah, maybe. Not sure. Sure, maybe. Neurovascularity intact. Are you going to order images? Yes. What would you order? X-rays. What kind? What body parts? What's that? Okay. So are you getting bilateral? Are you getting single? What would you do for a hip? You can get bilateral. That'd be okay. You'd also be okay getting just the left hip. You don't need to know this right now, but like a lot of times if you order like just the left hip, they give you a full pelvis AP, and then they give you just the frog leg of just the hip that you ordered. So you can do that, or you can just order the bilateral frog leg. That's fine too. With hips, I like bilateral because I can compare the two. Yes.
I'm suspecting that my fracture because it's also have to get a knee X-ray.
Expecting what kind of fracture?
Like a normal neck fracture, or you still have to.
Yeah. So good question. So the question is, hey, if I suspect a femoral neck fracture, do I still need a knee X-ray because joint above, joint below? So it depends on what you're looking for, right? If you're concerned about the hip in general, remember we talked about the joint above and the joint below when you're trying to evaluate an entire bone. So with a femur X-ray, you have to have joint above and joint below because you're not seeing the whole femur. If you're convinced based off of your physical exam and the symptoms that it's within the hip area, you don't need the knee because you're just checking out the hip, right? If you know, yeah, so just to answer that question. So if you notice when you looked at our elbow X-rays, almost all of our elbow X-rays was just the elbow. I didn't have the wrist or the shoulder, and that's okay. But if you're concerned like mid-humerus or mid-radius ulna, and you're getting the bone, that's where you need both. And that's where instead of a hip X-ray, I would be ordering a femur X-ray. Good question. Okay, so how would you write the order? This is practice for ClinCore and practice for clinicals, so you guys don't look smooth when you're ordering stuff in phase 2, right? 24-year-old female, 3 days of left groin pain, no trauma, limited range of motion due to pain. That's probably all I would really put, right? The radiologist doesn't care about the 5 to 8 out of 10 pain. They don't really care about the no relief with rice and NSAIDs. That's for you as the clinician, right? They care what's their trauma, where's the pain, what other can you give them? Just limited range of motion would be fine. Not really, not for a radiologist. No, you do as the provider. But yes, if they care about the level of activity with the workouts and stuff, the radiologist doesn't really care that much. When they care about mechanism of injury, they care about trauma, not trauma, if so, how, because they understand how the bones work and the muscles and how they break and bend and all that. So that gives them that information. As far as the fact of it hurts more when I walk as opposed to, you know, it hurts more when I run, but walking is fine, like they don't care about that.
What about the strength?
Radiologist isn't going to care, important for you, right? Would be important for ortho if you to send them there, but again, from reading the image, just the radiologist in a dark room doesn't really hurt them, or doesn't really matter to them in that aspect. But the limited range of motion is helpful. Okay, here's your picture. I know. You know how hard it is to find good femoral neck fractures? What's that? If they're in the slideshows, they're not on the test. Sometimes there's like one or two that slip through and I didn't realize because I have limited supply, but usually they're not. Alright, so since we've seen before, we'll go a little bit quicker. Right? There's the normal that's showing you there, the break there, and the break there. This was already kind of went over this x-ray. Okay? Femoral neck fracture. Why do you think the palpation was normal? Like I said, palpation normal. It's deep, right? There's a lot of muscle here. It's hard to actually press down on the femoral neck when you're just doing your standard palpation you do on physical exam. So it's not uncommon for this to be normal palpation because really what are you palpating? You're palpating all the muscles, right? Especially with where the femoral hip's at. Like you would really have to dig down there, and I'll be honest, once you're getting in clinic, you're not pushing that hard on a lot of these patients to really see if you can agitate the femur or the femoral neck. It's your range of motion and your strength through the pain that tells you there might be something going on here in the femoral head or the hip. Yes?
Just to clarify.
Yeah.
This frog leg is a pediatric.
No, a frog leg is, basically the frog leg is a descriptor of the lateral hip x-ray. It's not just for pediatrics.
When would you like me to get that order?
You don't have to. You just need to order the hip, and you would order bilateral hips, and that's what you would get. Yeah.
If there's no trauma at all, would you be concerned about like osteoporosis or something like that?
Maybe, but again, at 24, right? And I would say there's no direct trauma involved, right? She didn't fall and hurt herself, but what do we have at the end of this vignette? Her occupation is a firefighter. That by nature of doing your daily activities, stuff like that, is traumatic. It's just not there wasn't a direct trauma that happened. Like she had something that hit her, she didn't fall or anything like that. On top of that, she's doing 2-a-days of CrossFit, right? So that by nature, again, too, is somewhat traumatic to our joints and things along those lines. So although there's not a true trauma, how we identify it, what you're probably seeing here is repetitive pressure, repetitive trauma over time. Now, if you wanted to, after you fixed this, maybe order a Depson just to make sure, just to give yourself a little happy zone that it's not osteoporotic, you could. I will tell you that as you guys get better at looking at these things, you will be able to tell just by looking at the density of these bones that this is not osteoporosis, once you get better at looking at it. Okay, so there's that again. So what is it? A femoral neck fracture. What do we do for it? Next semester. Next semester. And you can do that as long as you've done your full workup and you have to say this is officially yours. Don't just send chronic hip pain or chronic back pain or shoulder pain with no radiological abnormalities to ortho. Don't do it. Ortho surgerize. If there's something to surgerize, they don't want to see them. A lot of the injections that ortho does, y'all can learn in phase 2 and do in your own clinic. Right? I did knee injections, AC joint injections, shoulder injections, I did it all. It's all based off of how much practice you get in phase 2, how much initiative you have, how comfortable do you get with it, and can, and just incorporate it, oh yeah, I can do an injection on that, right? So they don't need to go to ortho for those kinds of things. You can learn those and do those in your clinic. All right.
Question.
Yeah.
So on that last one, so someone had avascular necrosis right there, it was also fractured, but it would be like a vignette type, so what was it?
So, avascular necrosis. So let me ask a question back at you on that aspect, right? What area of the hip were we concerned for avascular necrosis? The femoral head. Remember, the femoral head and the scaphoid, not the femoral neck. Different blood supply, different areas, right? So don't get those confused. So if this were avascular necrosis, let's go through that real quick. So avascular necrosis was femoral head and scaphoid is an area that disrupts that blood supply, so we end up with that dead bone, right? So remember that you can have a fracture of the scaphoid or a fracture of the femoral head, and if you catch it early, you don't have avascular necrosis yet. That's what happens when we miss it, okay? The bone starts to die, and we start to get that sclerotic bone in this area of the, really in the femoral head. It would be more radial opaque, right? This is because of the overlying with the acetabulum in the pelvis. So we get sclerotic bone first. That's what brightens it up. That's that focal increase in bone density, the sclerosis. And then, specifically for the hip, once that bone really dies, that's when it starts to compress down. If you go back and look at your slides and you look at the avascular necrosis on the femoral head, you'll see how flattened the top part of that femoral head gets. That's really late stage. Okay? So just remember, that's a femoral head issue, not a femoral neck issue. Good question. Does that clear that up? Okay. Charlie case. 63-year-old male, follow-up of knee pain. Worst knee pain for many years, multiple repeat minor traumas during active duty, multiple courses of physical therapy, not PT like out there doing PT, that's physical therapy, and multiple knee injections which are no longer helping. Listen, he just wants to ice fish. He's retired. He retired in Alaska because a lot of people in the military were stationed there, trying to retire back in Alaska. Very friendly from an active duty standpoint. He just wants to ice fish. So, you look at it, you have varus alignment of the lower extremities, bilateral medial joint tenderness to palpation, limited range of motion, both active and passive, but he's strong, he's symmetric. All the knee special tests you guys just are learning right now are all normal and intact. Would you order images? Yes. What would you order? X-ray. Okay, so I'm going to piece it all together. I heard it from all different areas, right? So good, bilateral knees, weight bearing. Weight bearing bilateral knees. Good. How are we writing the order? Think about it in your head. So something along the lines of 63-year-old male with bilateral knee pain for multiple years, no recent trauma. Yeah, please eval for any abnormalities. Pretty much that's, right? No recent trauma, bilateral knee pain for multiple years. This will be a very common order for you guys, especially those of you who are seeing not just active duty, but retirees or dependents. This will be a very common one. And here's your pictures. Take your time. Try to find, sorry, I know you all are like, this is osteoarthritis. I already know this, right? But what I want you to do with this one is see if you can remember, right? Just looking at it and going, osteoarthritis, great, moving on. I want to see if you can remember and recall all the little things that are the signs of the osteoarthritis in this image. Right? There was a list of kind of little things we kind of went over and covered. Go through it, see if you can see them, see if you can find it. So that way you're not just relying on history, right? You can go through the X-ray and be able to pull this stuff out. Give you about a minute or so to kind of take a look at it. More time? Bless you. More time? More time? Good? Alright. What are these guys?
Osteophytes.
Osteophytes. Bony overgrowth around the most common areas of inflammation, one of the hallmarks for osteoarthritis. Good. Did we see the subchondral sclerosis? Or the fact that there's like no joint space at all right there, right? Another word for that. It's still having some sclerosis in that area where it's really, you can kind of have a little bit on this side too. Good. Joint space narrowing. You know, you guys picked up on that because that was kind of like osteoarthritis, all right. And how do I know that's joint space narrowing? Because I looked at normal knee x-rays and I know there's supposed to be a joint space there. Bilateral knee osteoarthritis. Primary or secondary?
Primary.
Primary. What are your hints for primary? Bilateral. Age, right? Years, prior active duty, all that kind of stuff. Age and bilateral are your big ones. This was a 23-year-old and it was one knee, and they had a history of a torn ACL when they were 17 playing football in high school. Probably secondary. 39-year-old male with 1 day of pain in the left ring finger after getting his hand tangled in a rope while on a cattle drive. Pain is 5 out of 10, worse with movement, localized to the proximal ring finger. Rice has helped a lot with some topical salve from his grandfather. He had leftover from an injury 10 years ago. Love it when patients just use crack and sit in their bathroom. From like, oh yeah, my dad used to have it. Cool, when did he get it? Oh, he passed away like 7 years ago. You still have it? Yeah, I just found it in there, started throwing. Fantastic. All right. Don't use things that are expired. Overall general appearance, normal male, well developed, well nourished, blah blah. Right? But we have left ring finger swollen proximally. Positive tenderness and palpation over proximal left ring and long finger. Know your fingers, right? The odds are, academically, we're probably going to have first digit, second digit, third digit, fourth digit, fifth digit, potentially. I think it could be ring or long finger, but number one, thumb is number one. This is not number one, so just make sure you know that stuff. Limited range of motion due to pain, 4 out of 5 strength, no special test for the fingers, neurovascular intact. We know what the next slide's going to say. I know you're already thinking about it, so yes, we should get images, right? Left hand x-ray or left finger is fine. Kind of like the hip, if you order just a right hip, right, they give you a full pelvis at first. If you order just like a left finger, you'll get a whole hand and then the oblique and the lateral of just that finger. Just order a hand x-ray. Don't order just the finger. That way you can see everything. So 39-year-old male, 1 day of pain, left ring finger after getting hand tangled in rope. Pain over proximal ring and long finger. There's my radiology request, right? Please leave out for any abnormalities. Thank you. Be polite. So we just did that. All right. Here's your x-ray. More time. Good. Here's now comparing it to a normal X-ray. All right. Did you find the ring finger fracture? Good. I want you to look there because that's where the pain's at. That's where it first started. That's the concern. Did you stop looking at the X-ray after you saw the shiny toy? No. Why? I told you not to. So then did you find that fracture? If I didn't tell you in the vignette that there was pain in the long and ring finger, would you have found it? This is a question for yourself, right? If I didn't tell you that, would you have found it? And at this point, I think with most of you, the answer is yes, I would have if you didn't stop at the shiny toy, right? Most commonly what ends up happening in these things is you guys get, again, you get excited, you see the shiny toy, you think you know the answer, and then you forget to go through the rest of the stepwise process, and then you miss the other stuff. It's not that you wouldn't have seen it, because typically when I sit down with folks and they kind of go over it, I'm like, oh my God, it's right there. I cannot believe I overlooked that. It's not that they don't know how to find the fracture, it's that they just didn't do their whole process. What's going on there? Did anybody see that? Good answer. That is a soft tissue shadow. Now we talked about bone shadows a little bit, but this one is not the bone that's hiding it. It's the soft tissue of the fourth digit coming down in there. That is not a fracture. How do I know it's soft tissue? Well, when I go through my stepwise process, I see my skin. I see my soft tissue coming in there. What's that?
So the first picture of it,
Yeah.
it does have it going into the middle. But on the next one, it doesn't look like it.
And so that's where, so like here, like you, yeah, because that one doesn't look, it's just the soft tissue.
Right. Yeah.
That there?
Yeah.
What is this line here though? Is that radio opaque or radio lucid? But yeah, I mean, that's, I would want more pictures, right, maybe, right? So if you're doing that, so for those that were asking, he's talking about, I moved the yellow circle, that maybe there's a little bit of a horizontal kind of radiolucent line in here. What's difficult with that, right, because of the soft tissue shadowing, we don't know. I want that PA to really look at it, and in real life, you look at those. But I like that you guys are looking at other things, right? And let's say this happens on a test. Let's say this image is the only one you get, and one of the choices is second, third, and fourth, right? Fracture. And that's the wrong choice, but then we go over and I look at it and go, okay, I can see how that could be interpreted. I would need to give you more images, and that would be one that's, hey, my bad. I'll give dual credit on that because I didn't see that originally, and as I told you, sometimes some of these things are hard to like get just the thing I'm looking for. At this point, the iteration is, most of them are pretty solid because I haven't had that happen, but I removed those questions completely and just do new ones. So they're pretty solid, especially for block one for sure. Pretty solid. So, all right. So there's a soft tissue shadow. So what do we call this? Middle and ring finger proximal phalanx fractures. You notice I'm not describing the direction on this one, right? Why? Well, we go away from the circles. They're in a lot of different directions, right? I'm just gonna say middle and ring finger proximal phalanx fractures. What do we do for it? Ortho. We'll tell you. Okay, why don't we just, I know it's early, but let's just take 10, come back at like, let's take 15, come back at like, oh, remember, so a couple of things on the break, right? Remember thoracic spine x-rays, are not going to make you count. If I need you to know a certain one is T4, T5, T8, whatever that might be, I will label it for you, okay? So that way you can see it. However, cervical spine, lumbar spine, you are expected to be able to count that and label those if need be, okay? But thoracic, I can't do that. It's not fair. It's too difficult to tell. Also, we'll do the review today. We talked about it, right? I will be available pretty much all day tomorrow, unfortunately, except for 12 to 1 because I have to run a meeting. Yay. But that means if after you do the review and after you're going through the stuff, you have some more specific questions, you want to clarify a couple of points, you do one of two things. You can email me in Canvas if you want, but being that it's during the duty day, if you want to, in Canvas, right, it has my cell phone number there. It does say emergencies only. That's primarily because before I put that, there was some students who it'd be like 9 o'clock at night and texting me questions while I'm trying to put my kids down. So, but please use that number to text me during the duty day. If you're just like, hey sir, you have a good time after 1 o'clock or whatever, that I can come by and kind of do that, and we can set up a time to meet in my office to come on by, and that will really help, because if you do that way and you text me to do that tomorrow, it'll help make sure that we don't have 5 people all coming at the same time. I'm okay, if you guys want to come in groups of 2 or 3, in case you have the same questions, I'm cool with that. But you've seen the cubicles, there's not room for 10 of you in there, right? But happy to do that. So please feel free to use my cell phone number tomorrow or even Thursday during the day if you got some time and you want to come by and get a few clarifying questions, and just text me. We'll set up a time to do that, okay? I am here for you guys to help make sure you understand that is what is important. All right, let's jump into another case. 32-year-old male comes to your primary care clinic with 1 day of right elbow pain after a falling injury. Pain is sharp, localized to the elbow, very minimal radiation into the forearm. 2 out of 10 with rest, but boy, 7 out of 10 when I start using it. Okay? Rice and Tylenol, haven't done a darn thing. I love how it puts this in there. Your face almost never use rice and Tylenol. Objective, well-appearing, well-nourished, well-developed male, no acute stress, sitting comfortable on the exam table, and vital signs are within normal limits. Visual exam is unremarkable. Positive for tenderness to palpation in the right lateral elbow. No other tenderness. Full active and passive range of motion, strength's 5 out of 5, but a little pain with resisted flexion, right? A little bit of pain when you're doing that, but they have the full strength. Special test, unremarkable. Neurovascular, intact. Are we ordering images? Yes. What are we ordering? An x-ray. An x-ray of what? Right elbow. Right elbow. Okay? So how would I word this one? 32-year-old male with 1 day of right elbow pain after falling. Patient is tender to palpation over lateral elbow. Great. Please email for the abnormalities. Thank you. I had a good question on the break too, now that we're talking about it. I'm not in the, we didn't really get into the weeds of I showed you, this is your frontal view, your AP view, this is your lateral view, right? But I'm not going to be asking you what view would you see this on, right? That's not anything you guys really need to know. Your radiology department is going to have standard operating procedures. What I encourage you is when you get to your clinic, ask that question. Hey, if I order a knee x-ray, what does it come with? Do they just do weight bearing just by the nature here, or do I got to order that special, that kind of thing? So you don't need to know, am I going to order an AP versus a lateral? That's just going to be kind of standard stuff. What you do need to know, though, is anything that I distinguished weight bearing, right? Definitely that is something that weight bearing versus non-weight bearing. Liz Frank is a perfect example, right? Because if you don't know to order that weight bearing, you order non-weight bearing, you're going to miss it. So those are the kinds of things, the AC joints, right? If you order them incorrectly, you're going to miss the abnormality. So those few things that were do this to see the abnormality, that would be fair game in that. But other than that, I'm not going to make you pick between a sunrise view of the knee versus an AP view in the knee or something like that, right? We didn't really get into that too much. What else was I going to say with, it'll come back to me. Oh, studying. We had a lot of questions of like, hey, do I need to know this? Do I need to know that? If it's not the history in the intro slides of like, it was created in this year by this person, right? It's going to be in the history, it's just more of background information. So if it's not the history slides, and it doesn't say FYI, it's fair game. The stuff that is not, you do not need to open the test, either says FYI or it's all those history slides of the modality, right? I'm not going to ask you when ultrasound was invented, right? I'm not going to ask you who invented X-ray. That's not important as a clinician. Okay. All right. So we already figured this out. We're going to order some stuff. And here are my pictures. Take your time, run through it. And then we'll talk about whether you use it or not too. Exactly. All right, more time. I think, yeah. Okay. So I'm going to use the light to highlight it because my next slide just has diagnosis. Right here. Everybody see the radial head fracture. Here and here. If you look closely, maybe there's a posterior fat pad, but really that's probably going to be more up in this area. Hard to see because this image is clipped, but I then challenge you with this question. Do you even need to look for a posterior fat pad sign on this image? No, because the fracture is right there. We use that posterior fat pad sign when we're evaluating an elbow image for a fracture, and we don't see a fracture. I can't see one. This looks normal to me. Now I'm going to shift to that posterior fat pad to verify that it's normal, because it's really using that to find those occult fractures, or just say, I can't see it, but I know it's there because I have the fat pad, which is why this image and not showing the full soft tissue in the back of the humerus there is there, because you don't need the posterior fat pad sign to pull out this abnormality. If this was a normal elbow x-ray, I would need to be giving you the full soft tissue area so you can appropriately fully evaluate it to make sure you're not missing something. Okay? But yes, that is a radial head fracture. Yeah?
What about the ulnar head? Like, is it like a centroid or is it a bulging head maybe?
Okay. So what he's looking at is this small little fleck of bone on the back of, it's not an ulnar head, this would be your olecranon process, right? Small little fleck right there. Does everybody see that? And the answer to that is I don't know. It could be a small avulsion. It could be the start of maybe osteophyte kind of starting to form and going to come together due to arthritic change or something like that. There is a small little fleck right there. I don't know what that mechanism of injury is. So, good eye. Okay. Now, I give you one, right? That is another elbow x-ray. We'll say same patient presentation. The first one was your 820, this was your 840. And you get the x-ray. Does anybody see the fracture in the elbow? shy. I sure don't, but I'm always open to learn. So if y'all are showing me stuff sometimes that I don't even see, which is good, right? I mean, it's good. But does everybody see the posterior fat pad sign? Right? This is not a normal X-ray. There is a fracture in there. We can assume it's most likely in the radial head. That's where the majority of these occult fractures are hidden, is in here somewheres. Okay? In here somewhere. When we look at it, what looks like a normal X-ray but has a posterior fat pad sign. There it is. What's that?
No, I said I hope they're not obvious. The posterior fat.
Sometimes they are, sometimes they're not. Do my best. So we call that an occult radial head fracture. If you go back to your slides, you'll see that. That's what that word is for like the invisible fracture. It's an occult fracture. Similar, a little bit different than hairline. Hairlines are usually just like the really fine lines. You can still usually see them on X-ray a lot of the times. Occult just basically means like I know I can't see it, but I know it's there because I have the fat pad sign. Yeah, occults are really good at hiding. All right. Okay. 15-year-old male comes in for a well child exam. Mother of child asks you to tell her son to stop eating so many donuts. He should put his phone away and go outside and play more. What's that?
I know the diagnosis.
Have an idea, but you don't know what I'm going to ask you yet on the exam, which is why you should read the question first and then the answers. Child reports he doesn't want to because his hip hurts. You do your physical exam. My favorite is the general I put in there, playing on his phone. You eat cheese puffs for your encounter. I get this, 15, like, I've had 4-year-olds come in like snacking and like eating like their little snacks. I've never had a 15-year-old just munching away on cheese puffs in the exam room. But, you know, it really kind of lays it out. Visual exam's unremarkable, right? He is mildly tender to palpation. Over the left gluteus, I think gluteal area. Could be greater, yeah, greater trochanter. I gotta spell that out. But gluteal area as well, greater trochanter, but full active and passive range of motion. It can move everything around, right? Because it's not a movement issue right now, it's a weight-bearing issue, right? That's when it hurts. Hence, the strength is 5 out of 5 in all of it, including the hips and the back and the knee and the ankle, but they walk with a limp. Okay, we didn't do any special tests. Neurovascularly attacked. Here's my X-ray. Give it to me, look at this. If you're on your slideshow, you can just go to the next slide if you want. It's a little more zoomed in. Let's see if you can find it on this one first. See if you can notice. Right, we already know we're looking for hip pain. Right? I specifically did not label which hip, because I want you to find which hip. If I tell you which hip, then you go to the shiny toy. Big red arrow. Go for it. It can be difficult, right? I've given you very extreme ones. I will agree with you that when you go to radiopedias, what you were saying, a lot of the skippies are difficult to see on X-ray. Agreed. Because what's another name for a skippy? Salter-Harris 1. When we talk about how subtle Salter-Harris 1s can be, right? So, but let's say you didn't see it on X-ray. If I give you this patient presentation, do you need it to suspect it? No, you do not. Right? Go ahead.
On the greater trochanter, is that a piece or is that not looking for
So don't look. So yes, it's a peds, right? But again, Don't look for the growth plates in other areas because remember I told you like different growth plates fuse at different ages. And I'll be honest with you, I think 15 is close to that age when the trochanter kind of fuses. So maybe it is here, and in some 15-year-olds it won't. So don't get hung up on should there be a growth plate, is there not? How do I know it's peds? Well, I told you it's a 15-year-old. Okay, that's step one. Step two is a Salter-Harris question. It's peds. But, so, on top of this, we're all adults here. Can we tell that these x-rays, even though those are normal and abnormal, that one's female and one's male? If you follow your soft tissue, you can tell. Just leave it at that. All right, so Salter-Harris 1, we got the slippage of the femoral head off of there, right? So, going back to your question, right? Couldn't tell on x-ray. Well, what do I have? I have the patient population that seems like that. No, we're talking clinic, right? I have the patient population that seems like that. I have unilateral hip pain. A lot of times this is unilateral, right? Like we talked about, if it was just activity and they're just sore from doing stuff, probably going to be bilateral because they're doing that activity. I get the x-ray is normal. What's my plan of care for that patient and that mom? Yep, everything looks good. Let's give it a week to a week and a half of rest. Have them try to get back into activity again. If it still hurts, come back and see me. Okay? X-ray again. Normal. Okay? Maybe we try the same thing again. Still having issues. What's my study of choice for a skiffy? MRI. And that's how you find it sometimes. Now, you may not even have to wait till then, because likely what's going to happen is you're going to order the x-ray, it looks normal to you because we look at radiopedia, I got you. We look at radiopedia and it's pretty normal, but then we have a pediatric radiologist who is like, at looking at these things. And they're probably going to go, hey, we're noticing a Salter-Harris 1, we see the skiffy, here's why, yada, yada, yada. And then you just have to call back and go, hey, I did that wet read, it looked good to me, but our pediatric expert looked at the x-ray, they actually did find this, so now we're going to get you to ortho for care. So you really don't have to worry about missing something like this too often, as long as you order the x-ray, because your pediatric radiologist will likely find it on their report. But if not, know that don't just accept that report as normal and be like, well, there's no reason to take the next step and go to the MRI if they're still having pain, because it might be so minute that even they don't see it, right? We're all human. So know that that MRI is that study of choice. Yes, sir?
In the bilateral hip x-ray version of both,
Yeah.
the pubic symphysis looks really spaced.
Yeah.
And
Pediatric.
just pediatric.
Pediatrics, right?
And the right SI looks wider than the left SI. Is it also just like angle with the x-ray? Not that one, the first one, the slide prior.
Oh, okay. So yeah, so look at how this, see how this patient is rotated? See how they're angled? That can cause some skewing of some of that stuff. But again, I don't want you to get too hung up on pediatrics when we look at the pelvis and the fusing, because that's going to vary by age as well. Like even this right here, right? These aren't fractures. The pelvis just hasn't fused yet. So we're very specific to talk about in the peds areas, because that can get very confusing. There it is, Skippy. What are we going to do for it? Send it to ortho. They'll tell you next semester. Remember this one? From the beginning. Femur shaft fracture with apex lateral angulation. This is an AP femur x-ray, right? I'm not going to ask you specifically on the image, but that is what that is. What do we got here? Say it again. Depression fracture. Not to be confused with compression fracture, which is for the vertebrae. Right? Depression fracture, right here, depression. The skull was depressed. Not sad, it got depressed. That was psych, that was last one. Was that the second or first psych test? First. So, depression fracture, not to be confused with compression fracture. how useful is this with weights for you? If I have with weights, what am I most likely concerned about? What body part? AC joint. Now, full disclosure. Once you get to phase 2 and you get out in clinic, this will be useful to you on its own. But we rarely order it with weights, only we will order it with and without. So I'm just telling you that this one is with weights. This should be nice and in line. Maybe a small, right? Maybe a small little kind of gap there if we need to, but I mean, this is almost the thickness of the clavicle up. So this is an AC joint sprain, an injury. You don't need to know the grades. That was an FYI slide. Or we'll talk about that a little bit, but this is a grade 2. All right. Go through this one. Tell me what you see. Tell me if you see what you see, why you see it. I'll give you a minute or two on this one because the pelvis has a lot to go through. Let's say the patient is coming in and they're having some left hip pain with prolonged activity. They're walking around the neighborhood a little more often, walking the dog, and they're just starting to have some left hip pain towards the end of their walks. Gets better with rest, but depending how long the walk is, it can be up to a 6 out of 10 when they get back. It's been going on for about 4 weeks. Need more time? All right, you ready? It's a normal x-ray, everybody. It's a normal x-ray. This is common. They will come in with the symptoms. They will come in with the complaints. You're fully expecting to see something, and there's nothing there. This is going to be the most of your x-rays. Completely normal. Completely normal. Yes?
So, it's like small things that kind of look like maybe osteophytes, but
Here?
no.
Where?
Like just a portion of the whole head on the left side.
Oh, left side.
Right there, that little thing.
Okay. Maybe.
Osteophyte or something. If you have this, you're not going to get some good sense. You're just like
Something as mild as osteophytes?
Yeah.
Yeah, no. Because what are osteophytes? Osteophytes are indicative of osteoarthritis, right?
kind of the description.
So, but would you, if you looked at this and look what we talked about, what we've seen picture-wise, pull out just that one thing and be like, oh, this is definitely, because what are we talking about? I would want to know, let's say this was an older patient, right? And it's primary osteoarthritis. It should be bilateral, right? Now, if I would not do this, but in order for me to buy this as a arthritis thing on that, maybe if she had a labral repair on her left hip 5 years ago, maybe a secondary if we were going to go there, but I would have to give you all that in a minute. And honestly, I just made up all that story on the spot, just to get you guys thinking about how a patient's going to present, to know that, like, hey, just because they're having pain in a certain area, I probably should have said right hip, and then we wouldn't have to worry about that, but I just threw out a hip, I made it all up, so, yeah. All right. Oh, I remember something about this. I remember something about this. There were a couple of names, depending on how many pieces of something were there. What's that? Cesspool, good, it's not a fracture. Yay. All right. Ready? Rolando. Now I'm going to take away the old lines. I mean, I know on your slides you don't have them, but I'm going to take away. Do you see the three pieces? Two are very, like, right, I mean, boom, right, there's one, right? But then when you follow the cortex down, I got a break in the cortex here, a break in the cortex here, and whenever you have breaks in the cortices, then you're going to start looking even more in that medullary area, right? Break in the cortex, follow along in that medullary area right there. So I got 1, 2, maybe 3 or 4, but definitely more than 2. So that's my Rolando's fracture. Remember, base of the first metacarpal. Uh-oh. And we're going to end with the giant train wreck right in front of your face. Right? I'm just going to go to the next one. There it is. Right. Open low pelvic injury, pubic symphysis widening, plus that SI joint, especially when compared to the SI. Which SI joint is this? Right SI joint. You guys are going to send me the testimony for like a 96 average. Watch.
Hell yeah.
Do it. Do it. I would love to sit in there and they'd be like, why were there like 20, 100% questions? Because they learned their crap, okay? Do it. Whoa! What's going on here? Which way? Right? Where's that femur going? Right. Where is it? Anterior. Again, you look at this in your eyes, boy, that looks posterior in that femoral head, doesn't it? It's playing tricks on you. Your brain wants to think in 3D with a 2D image because we live in a 3D world. Not a Barbie world, a 3D world. Right? So that is an anterior hip dislocation. What the heck is this radio opaque line going up? Huh? Catheter. That is the catheter. This patient obviously is hospitalized because when you dislocate your hip, that's where you go. But yes, they have a catheter in. That's what that is. What questions do you have? All of them, right? Can we go through all 7 slides again? Yes. We don't want that. Okay. Thank you for your time on block 1. As a reminder, when I come back for the review today, it is optional. I already have one topic that I'm going to address because I had a couple of questions on it, and it is a little more confusing, so I want to try to clear that up a little bit. But then it's just going to be Q&A. I will have all 7 slideshows up. Slideshow 5, slide 17. Let me pull it up, ask your question, right? And then we'll go through it. And then sometimes I'll start talking about it, and then we'll stem kind of things that are similar. So I will tangent a little bit to things that are similar and important and kind of break that down. And then at the end, I'm going to say, did that clear it up? Please be honest if it didn't, because my goal is to clear things up to make it better for you guys to understand, okay? And that's how we'll do that. You can leave at any point during it. You don't have to be here for it. But I'll have those all pulled up and ready to go and be here for you guys. Questions for me right now? Okay, cool. We'll see you guys later this morning.